epidermal hyper. When you take out, before that, actually, let's talk about what happened in the breast. So during lactation, you will see that the breast is going to undergo a lot of changes. This is a non-lactating breast, where you see that the lobules, are very well, circumscribed, confined, really. There are a lot of empty spaces, clear spaces between the lobules. And then if you go down on this lobule, the lobules are really, have the smaller, glands and very tight glands, as opposed to what happened during lactation. As a result, of the effect, of hormones on the breast, you will start to see that what you call, gland to gland, or glands that are side by side. And that actually, if it was not in lactation, it will be worrisome, because the minute that you start to see, side to side or wall to wall, whatever you want to call it, then you have to wonder if there is any cells that may have gone, neoplastic or malignant. But that's not the case here. It is simply lactation, and you can see that the glands and the ducts are filled with this, inspissated, milk that is going to be, expressed eventually. All right, let's talk about, and then there's the compensatory hyperplasia, also physiologic, but compensatory because it's going to follow loss of an organ. In this case, I did mention to you the liver. You take out part of the liver, and in no time, within 12 hours afterwards, you will see that the liver cells will start to divide. Why that happens? Because those cells will realize that they are missing their contact. I mentioned to you the word anoikis last time. All right, one thing actually I wanted to change the anoikis, if you have written it, by contact inhibition. This is what epithelial cells do. When they are contacted by other cells from nearby tissue, they will cease actually division. Okay? Whereas malignant cells will not. Malignant cells do not really care if they are contacted by nearby cells or not. They will keep dividing, uninhibited. So contact inhibition is one of the features of benign cells. Okay. Now, anoikis is something else. Let's not get there. But it is also related to contact. But I did mention to you, it was the last thing that I mentioned in the class, and I wanted you to actually change it to contact inhibition. So contact inhibition is the right, is the right context, of how these cells, stop dividing when they are, going to be, surrounded by nearby cells or progenies, or actually when they are going to start dividing when they miss this contact. Again, it's a feature of benign cells. All right, now pathologic hyperplasia. Usually hormonal, growth factors stimulated, that's going to be, and that could be also, including mechanical factors. For example, irritation, skin irritation, as I mentioned to you, one of the reasons of why that happened. Now, endometrial gland hyperplasia, I'm not sure if I mentioned that, but in this case, you will see that during menstrual cycle, normal menstrual cycle, the tandem effect of estrogen and progesterone is going to result eventually in the gush of blood that happens during menstruation. Now, if that does not happen, if there is any kind of disturbed balance between estrogen and progesterone, the end result is going to be bleeding throughout actually the cycle, what you call dysfunctional uterine bleeding, or DUB. Okay? Abnormal menstrual bleeding. So during that time, you will see that instead actually of the estrogen growing and increasing, and as a result of that, there is endometrial hyperplasia that will be followed by the progesterone in menstruation. In this case, you will see that estrogen is throughout actually the cycle. So there will be a lot actually of hyperplastic glands that are going to be, and this actually hyperplasia is going to result in bleeding throughout what is known as DUB, dysfunctional uterine bleeding. All right. On the other hand, there are other pathologic examples of hyperplasia. I guess much easier to explain than the endometrial hyperplasia. That polycythemia. Polycythemia is defined as increased redness, right? Polycythemia is redness of the blood, which means increased RBC mass. Now that you see actually either as a neoplastic transformation of the mother cells of the RBC, what's known as polycythemia rubra vera, PRV, or actually has an increase of EPO. Now here what we are talking about, we're talking about EPO, okay? EPO increase. Where does EPO increase? The erythropoietin. So EPO increase, when there is any reason actually that is going to result in decreased PaO2 that is going through the kidney. So as a result of that, so let's say that actually there is anemia, okay? Anemia. As a result of that, you will see that the EPO, those receptors in the kidney are going to sense that the PaO2 has decreased, and as a result of that, the cells that secrete EPO in the kidney are going to start to put in EPO in the blood. EPO will go and work on the bone marrow, and as a result of that, you will see what is known as erythroid hyperplasia, and that's going to result in increased RBC mass, to correct the deficiency that happened. Now that may happen also, as a result of a tumor cells that secrete, the EPO. That could be in the kidney or elsewhere in the body, what you call aberrant production or abnormal production of EPO by other tissue other than, those cells in the kidney. Now that may also happen if you have a tumor that is pressing on, the blood vessels that take blood to the kidney. For example, liver cell tumors, or adrenal cell tumor that have gone out of its normal space and has started to compress the renal compressed the blood coming to the kidney, resulting in decreased amount of blood coming to the kidney that will be translated as a low PaO2. I'm gonna pick some of them, not all of them. Let's talk about what happened in chronic irritation. So bronchial mucus gland hyperplasia in smokers. So that's going to be the first step, in which those cells, those poor cells in the bronchial tree and the trachea are going to respond to the effect of smoking. So first, by trying to make actually the epithelium thicker, or by the mucosa thicker, in this way, it will try to prevent the effect of the poisons that are in and the toxins that are in smoking, on the underlying tissue. That of course will not matter, and you will see that it's going to be followed by another step, which is going to be metaplasia eventually. Let's talk about stimulating autoantibodies. As you know, there are two types, of autoantibodies. There is the stimulatory, and then there is the inhibitory. And the stimulatory, that's what you see in Graves' disease, which is a subtype of hyperthyroidism that is resulting from the production of autoantibodies that are going to be similar to the TSH, and in this way they are going to make the gland go into a hyperdrive and put in a lot of T3 and T4. Does Graves' disease have inhibitory antibodies as well? So it has stimulating antibodies. Does it have inhibitory antibodies? It has been shown that it may actually have inhibitory antibodies. On the other hand, Hashimoto's thyroiditis, in the other hand, what's the other form? Yeah, Hashimoto's thyroiditis, which is a form of what? Hypothyroidism. So the other question would be, does Hashimoto's thyroiditis have stimulating antibodies? And the answer to that is yes too. So a lot of people believe actually that Hashimoto's and Graves' disease are a continuum rather than two distinct entities. Continuum of the same, actually in the same line. So you will see that those patients may have actually a mix of both antibodies in the disease itself, in the person, in the same person. And there has been a lot of studies coming out of Canada and the US that showed actually that Graves and Hashimoto's happen in the same families, and that there are patients actually who of Graves' disease who are going to go into actually what you call Hashimoto's and vice versa, to the point that now actually it is mentioned to be what is a coined phrase for that. They call it Hashitoxicosis, that Hashimoto's that have turned into hyperthyroidism and vice versa. All right, just a point. So again, stimulating antibodies, that may also do the same because they are going to act as a TSH, and as a result of that, they are going to work on the cells of the thyroid, the thyrocytes, making it divide and making also its hypertrophy. So in this case, So you will see that in this case that you will see that the end result is going to be both hyperplasia and hypertrophy that's going to manifest clinically as goiter, right? So the big gland in the middle of the neck. All right. So let's talk about okay. So how does it happen? Why does it happen? Or when does it happen? Actually, probably the best thing to talk about now. It happens only depending on the type of cells. So if the cell is able to divide, then the cell, that stimulant that's happening to the tissue will result in hyperplasia. That's what you call the cells that are able to divide, especially those that are able to divide continuously, is what you call labile cells. On the other hand, there are cells that divide only when they need it to divide. That's what you call a stable cell. For example, liver cell. We take the liver out, the cells of the liver at that stage will start to divide. And then, as you know, there are the cells that never divides, that are going to be, simply are going to respond to those kind of, stimulants from the outside in the form of hypertrophy rather than hyperplasia, such as what you see with the muscle and the neurons. Now, regardless really what you are talking about, which pathologic hyperplasia you're following, one of the things that all pathologic hyperplasia will have in common is that, there is, once you cease the stimulant, the tissue will go back to normal. It will not keep on growing. And that is an important distinction between hyperplasia and cancer, okay? Now, that has become a little murky in the recent years because now we have what you call atypical hyperplasia. Now, again, the schools of thought in medicine are, are really many. So there are people who don't believe in anything called atypical hyperplasia, and they lump it under, dysplasia or atypia. Regardless, in general, when you're talking about pathologic hyperplasia, by definition, you mean that it is still at the hyperplastic level rather than at the neoplastic level. And there are features to look for, to differentiate between the two that you're going to be getting as we go through this block. Now, what the other way to look at it is that when there is a hyperplasia, there is always a chance that cancer may be lurking, maybe somewhere actually within the section that you are examining. So that's why, hyperplastic conditions requires very difficult, very delicate kind of, examination of the tissues that are submitted to pathology. All right, so we talked about the lactation. Now, here are examples of what you see in different entities. I'm not gonna, usually I don't like to ask, like what do you call it, a straight, answer. It's gonna be mostly in the form of a clinical, question. If there is any straight answer, it has to be something that you need to know, such as the most common or a least common. So you may actually go over this on your own. I'm not gonna ask you anything from it, but these are examples where actually excesses of, hormones will result in, hyperplasia in the end organ. All right, so here are examples of, of endometrial hyperplasia. So when you look at the normal endometrium, you see a lot of interstitial space. The cells are not, back to back. That's the word that I have been looking for this morning. So their cells are not back to back, and they are pretty open and of various sizes. Okay? Now, what happens in hyperplasia is that the cells become a lot more than what you see here. That's when you start to say back-to-back glands. The name itself, this phrase itself, will raise, the eyebrows of pathologists because they will have to dig deeper into, the type of glands that are here. Are they normal glands or are they neoplastic glands? Are they, transformed glands, meaning they have started becoming cancer? And there are features that you need to look at the architecture. For example, the malignant gland will start to take a shape of what you call actually infiltrating shape, or there are other words for it, but infiltrative. You will see a jagged edge, simply, like a gland with an invading front, that is going to be in the form of a sharp, sharp edge, for example, and it will be, cleaving through the tissue. It will look very much like that. That's actually, that's the definition of cancer wherever you go in any tissue in the body, is that it has to have an infiltrative pattern to it. So that's what you call the architecture of the tumor. And then you go on higher power and you start to look at the cytology of the cells. There are features of the cell at the level, of each cell that is going to tell you that what you are dealing with is a malignant cell versus a benign cell. For example, we don't need to dwell on it too much because we'll get to it. You start to see that there is more nucleus and little cytoplasm. That tells you that the cell is in a state of hyperdivision. So that's actually when you see that the NC ratio is raised. That's a feature of malignant transformation, one of many features that you look at in malignant transformation. Now here's the example that we talked about here, which is this nodular prostate, and here you see that again the features that we talked about when it comes to to histology. You see that instead of just 1 or 2 layers, you start to see piling up of those cells, but these cells are still benign. Why do you know that they are benign? The most important feature is that you look at the basement membrane, and the basement membrane of those glands are still intact. There's no breach of those basement membranes, so those cells are more or less benign. Now you go on higher power and you will start to see that there is still a lot of cytoplasm. So the NC ratio is pretty low. You go also and start to look, you cannot see it, but only pathologists can see the NC. We see stuff that nobody else can see actually. This is a joke, and also it's actually true at the same time. So even from this higher power, you go and look at those cells, and you will see that the nuclei are pretty small. One of the features of prostatic adenocarcinoma is that the nuclei have actually to meet a certain measurement, to call it actually a neoplastic cell. So one of the weaker features of a neoplastic, a malignant prostatic cell. All right. So now case 2. This is hyperplasia. So again, with hyperplasia, there is a risk of transformation. There's a high risk of transformation because it's a glandular. And what happened is that after a while, if the hormonal effect keeps on going, and after let's say years, decades of the effect, that may actually move from a hyperplasia into a cancer. Okay. And now the cancer itself is not really it's not what we talked about yesterday, the other day. The cancer is an independent process. It is a cell that marches to its own to its own design, to its own mind. How does it do it? How does the cancer cell do it? Do you guys know? Why am I saying that the cancer cell does not need anything from the outside? It marches to its own tune. Where is the brain of the cancer cell?
The nucleus.
Nucleus. And what happened in the nucleus to make it cancer?
The
mutation, exactly. It's a genetic disease. Cancer is a genetic disease. Whatever type of cancer, it is a genetic disease. The genetic mutation or translocation or actually a deletion or whatever it is going to result in one effect. That is going to make the cell independent. Okay? Now you add hormone to it. Okay? So it does not need to be hormone to become actually cancerous. But you add hormone to a cancer cell and the cell will grow like wildfire. Okay? So again, things to keep in mind. All right. Now, case 2, in this case, we're going to be talking here not about hyperplasia, but about hypertrophy. And for this, we are picking a tissue that does not divide, or practically speaking, does not divide. In theory, it does, but it takes forever, as I mentioned to you. All right. So here, a patient who's at 40 years of age presents with a heart murmur 8 years ago. Now the patient is actually presenting to the emergency room with a complaint of chest pain and severe shortness of breath. As I mentioned, 8 years ago he came in with a heart murmur. Like our patient in the Middle East, he neglected this heart murmur. It's nothing, just let it go. It will go away on its own. It did not go away on its own, and the patient eventually, presented with this, shortness of breath and chest pain. In the hospital, they did X-ray for him that showed cardiac enlargement, and during his hospital stay, he had a cardiac arrest that resulted in his death. So, autopsy finding, they did the autopsy. This is the QC. This is the quality control, quality assurance, believe it, tool of the hospitals. So a lot of physicians hate it because it shows you everything that happened to the patient during his stay. In this case, it was not really something that happened in the hospital, but rather something that happened to the patient as a result of his neglect. There was an enlarged heart, where the aortic valve was actually calcified and stenosed, so there was narrowing. What happened as a result of narrowing of the aortic valve? So let's say that there is, either aortic stenosis or there is a hypertension, which means what's going to happen? The heart will work harder, right? If that is actually happening over a couple of hours, as a result of hypertension, and then it's treated and controlled, no problem, right? But what happens if it's happening, day in, day out, over years? In this case, 8 years. This heart is going to be bulked up so much because it's trying to overcome this obstruction, right? In the process of doing so, it will result in cardiomegaly. Okay. Now, that actually was, the shape of the heart during autopsy. Here you see the comparison between a normal heart and an abnormal heart. Abnormal heart. So you're going to be seeing that normal heart is about 1.2 to 1.4 centimeter in maximum dimension of the left ventricle. The right ventricle is about 0.2 to 0.4. You will see that the right ventricle is normal here, almost the same like here, right? But you go and look at, the left ventricle, and you see it almost, 4 times, that size, about 3 centimeter, even more than that, 3.5 centimeter in thickness. So that's actually what happened in this patient. What do you think made the patient die in this case? This is the heart. This is the actual heart of the patient. What do you see here? Go ahead.
Probably decompensated heart related.
Decompensated. Well, decompensated if you have a floppy heart, right? If that would have happened about 8 years after that, or 5 years after that, about 13 years in the process, because the heart first will get bigger, right? And then it will be remodeled in what you call floppy heart, where there is, congestive heart failure. Then he will die as a compensation. So this guy died as a result of something else. Go ahead.
He had shortness of breath. Was that because the heart enlarged so much that it obstructed, the lungs, maybe?
That, like mechanically speaking, that may actually explain it, but that's not really the way to think about it. Go ahead.
Is it because the electricity is having way too much time to move through the heart, so
not the electricity, something else.
The white, does it represent scar tissue?
Scar tissue, okay. Well, like you said the word, I did not want you to say. So, just 1 second, please. I carry. Not what I hear. I mean, no offense. But what's happening here is that, do you think if this is the first event actually of ischemia, okay, is there time, between his symptoms and death? He died, let's say, I did not give you that, so I will take that back. How about he died actually within 12 hours of admission? There will be not enough time actually to show the changes in the heart in the form of myocardial infarction, okay? Or, myocardial ischemia that we're talking about, the area that is going to be necrosed as a result of the infarction. But so what else would have caused actually? Cells are tired. I think students are tired. What's that? Just kidding. Yeah, go ahead.
Don't say pulmonary congestion.
I will not kill you unless it is actually resulting in a pulmonary embolus, for example, saddle embolus that will block, the 2 arteries. And the heart will be actually, pumping on empty. What you call that will result in what's known as a PEA, pulseless electric.
Because cardiomyocytes do not divide.
No.
Would there be fibrillation because the heart is enlarged?
What is it?
Fibrillation.
Fibrillation. How do you relate that to the enlargement of the heart? That's exactly what happened. So if not fibrillation, I would call it arrhythmia, any kind of arrhythmia, right? Ventricular fibrillation, flutter, whatever it is, right? So how would you relate that to ischemia, and how would you relate that to this? Again, if you go ahead, the last one.
Probably due to ischemia, that's why the currents couldn't properly conduct through the muscular tissue. That's why there was.
Nope. So listen to this. Where do the coronary arteries sit? On the surface of the heart, right? And then they send these penetrating branches into the myocardium, right? The longer those branches are going to go, the less likely that they are going to supply actually the underlying tissue, correct? It's much easier to supply, a thickness of 1.3 centimeter than to supply a thickness of 3.5, right? They have to cruise way long before they get to this part of the tissue, which is the most likely actually tissue to suffer ischemia, which is the subendocardial region. Now, why not the endocardial region? Because the endocardial region is bathing in the best blood in the body, which is the oxygenated blood that just came in from the lungs, right? So the endocardial layer will not suffer ischemia. The layer beneath it will be the layer most distant from the surface, from where the coronaries, have originated, and that's going to result in them actually suffering ischemia. But it is not really myocardial ischemia that resulted in this poor guy. That it is ischemia to the conduction system. So in a way, you two are right. So you will see that actually this ischemia that resulted, in ischemia to the conduction system, to the SA node, to the AB node, to the Purkinje fibers, to the Hess bundle. All of it are going to result in arrhythmia, and arrhythmia will result in death with a clean heart, because there is no time for this arrhythmia, to show up in the form of a myocardial infarction. Okay? Did you guys get that? Okay, so this is actually a quiz question that was on my board. What is the most likely finding to see in patients who died in a hospital from a cardiac ischemia in 12 hours of their death? And the answer to that is nothing. Okay? A trick question. Okay, so you take a section of this heart and compare it to this heart right here, and you're going to see a difference, because those individual fibers have hypertrophied, right, as a result of working against the obstruction. Not only that, you will start to see that their nucleus also have become larger. Compare this one to this one right here. Now the spaces between those cells are an artifact of fixation. It is not really, there are no spaces between muscle fiber cells. It's an artifact of fixation from formalin. All right, so what happened here? The size of the cell has increased. Now, where do you see that? You see that, for example, as a result of intentional, as an intentional act by, let's say by a medical student, or for example, for one reason or another, you want to go and, like work out in a gym, right? And the result is that you're applying resistance against low skeletal muscle that will result in hypertrophy. It may be seen, as a result of a disease, as aortic stenosis is one, hypertension is one, coarctation of the aorta is another. All of them are working against, an obstruction in the outlet, of the left ventricle, or just about, just out of the outlet of the left ventricle, resulted in hypertrophy. Uterus, on the other hand, in this case, you see both hyperplasia and hypertrophy. There are a lot of examples where you see, both hypertrophy and hyperplasia. Uterus, thyroid is another example of that. Now, removal of an organ, if you take one kidney out, such as, for example, when someone donated his kidney, you will see that the contralateral kidney will start to increase in size, and that increase is going to be in the form of hypertrophy. All right, so how does that happen? So again, as a result of the fact, that there are, what you call trophic triggers and stretch triggers, stretch stimulants, that's going to be in the form of soluble mediators that are going to actually propel the cell into making more proteins and myofilaments that will be helping the cell to contract better. That's exactly what happened in hypertrophy. Not only that, the other thing, so the first one, if I ask you a question like this on the exam, will be, if you say soluble mediators that will stimulate cell growth, that's all that I need from you. The second one is going to be a switch of those contracting, myofilaments from one type to the other, from the adult type to the fetal type or neonatal type, such as the beta form of the myosin, which has a better contractility than the adult type. So two reasons why the hypertrophy happened in those muscle cells. Examples of muscles, we did talk about hypertrophy. Here's an example of a skeletal, in this case hypertrophy as a result of weightlifting. This resulting from hypertension or aortic stenosis. Here's an example of a gravid uterus. Usually the uterus is a small organ, a small pelvic organ. When it becomes a gravid uterus, it becomes a abdominal organ, where you see both actually hypertrophy. In this case, you will see mostly hypertrophy and hyperplasia. So the cells itself will start to become bigger. You can compare those individual cells, with those cells right here, much bigger, much rounder, and that's gonna end after delivery, after the involution of the uterus, where the uterus will go back to normal, not completely, but as much as possible, actually going back to normal, following delivery and following, of the fetus and of the placenta. Here's an example of actually hyperplasia and hypertrophy. You see that with pregnancy, as I mentioned to you as one. The second one also as a result of iodine deficiency. All right.
Presentation.
All right, now atrophy is a completely different. So hyperplasia, cancer, right? How about hypertrophy? Does it cause? Is it related to cancer in any way? The answer to that, most likely not. Okay. Again, in medicine, you learn actually you never say never, right? But like 99.99999, hypertrophy will not result in cancer, and it is not related to cancer. Okay. On the other hand, because of the type of tissue that it is dealing with, because of the fact that those cells actually lack the ability to divide, that's a protective really mechanism if you think about it. This is one reason you rarely hear about tumors of the heart, for example. But there are tumors of the muscle, of other muscles, and you will get to know them as time goes by. Atrophy. How about atrophy? Is it related to cancer? And the answer to that is also no. Okay. Atrophy. This is a scale down of the cell. The cell will simply downsize from its original size, from its original shape, and it does that because of the fact that it is receiving less than it used to be receiving before, less blood, less nutrients, and one way to deal with this is simply to reach a new equilibrium that this diminished blood supply will be enough for the new size of the cell, for the cell to be able to live and continue its life. You see that again in physiologic conditions such as during early development and following delivery. You will see that there are structures that are going to simply go away, such as the notochord and the thyroglossal duct. What does the notochord give rise to? Is it on the spinal cord, the nucleus pulsus of the vertebral column. So related to the spinal cord in a way. All right. How about the thyroglossal duct? Let's say that it remains. What will it result in? Cyst. Okay. The thyroglossal duct cyst. Where will that cyst be located?
Along
This
the
one, right?
yeah.
As opposed to another kind of cyst that is also in the neck, but that's located laterally, which is the brachial cleft cyst. How would you differentiate between the two?
Movement.
Swallowing. By swallowing, what will happen to the thyroglossal duct?
It moves.
It will move, right? Okay. So what does the thyroglossal duct do actually in normal development? Through which?
The migration of
Of the thyroid, right? Okay. Now, pathologic, that's going to depend on the cause. Let's talk about the causes of atrophy. Either because you're not using it, they say if you don't use it, you're going to lose it. All right. So this is an example of that. Let's say someone had a fracture, and then as a result of that, they put his arm in a cast. One of the things that will result in this is atrophy of the muscles of the arm because of disuse. This is why actually you're seeing that even the cast, when it comes to orthopedics, have become smaller and smaller because you want to limit as little as possible actually of those muscles without resulting in the destabilization of the fracture that happened. Loss of innervation, such as what happened in poliomyelitis. In this case, stimulation of the muscle is gone. As a result of that, you see that there is what you call denervation atrophy. Reduced blood supply. In this case, that's going to be anywhere in the body. Let's talk about what happened at the level of the carotids. If the carotids are affected by atherosclerotic plaques, that is going to impede the blood flow to the brain. What will happen to the brain in general? In this case, the brain itself is going to actually suffer this kind of ischemia, and as a result of that, it will become atrophic. What you're going to find here, if it's a global kind of phenomenon, you will see that the whole actually cerebral hemispheres will become smaller in size. They will become, they will shrink in size. And you will see that the gyri will actually become thinner, and the sulci will become deeper as a result of loss of brain tissue. Renal artery atherosclerosis, another example of renal, an entity that will result in renal atrophy. We have an example of that. And the last one is inadequate nutrition, such as protein, calorie malnutrition. Now here's an example of atherosclerosis that is happening at the level of the branch of the renal artery. You will see that this atherosclerotic plaque has narrowed the ostium of the renal artery, resulting in you don't see the difference between the two because it is due to projection. If you look in your laptop, you will be able to see that actually this one is smaller than this one right here. Here's an example of that. You will see thinning of the renal cortex as a result of the decreased blood supply to the kidney resulting from atherosclerosis. Now, decreased hormonal stimulation. You take out the hormones that are going to propel the cell in division, and the organ is going to suffer from atrophy. Example of that, what you see, for example, following surgery to the pituitary. This is one resulting in panhypopituitarism, where you see all the end organs going to be affected by the fact that there are no more hormones. You see that following menopause in a breast, and you see that in a person who's receiving actually exogenous thyroid hormones. Because what happened when you take the drug to treat hypothyroidism, you're giving the patient thyroid hormones. Those thyroid hormones are going to suppress the TSH, and as a result of that, the gland is going to become actually atrophic because there is no longer a TSH that is going to propel these cells to divide in a normal way. Aging in itself actually is a big factor that result in atrophy. Example of that, what you see at the level of the brain, in cerebral atrophy. This is usually what time does the brain reach its full development and full size? Way before that. You wish. It's 25 years of age. At 25, it reaches the full, potential, full maximum, size that it is. And years and decades after that, it starts to, you start to lose brain material, but at a very minute, minute amount, until the age of 60. After that, you will see that as a normal, aging process, you will start to see that there is a loss between 0.5 to 1% every year after year, to the point that at actually the age of 75, you will see that the brain is going to be less, is going to be 15% less than what it was when it was 25. So there is what you call normal aging process. In the absence of any other disease, in the absence of any other disease, atherosclerotic disease, or any neurodegenerative disease, regardless of that, you will see that aging itself will give rise to atrophy. Increased pressure, here's another example actually, a great example of a pathologic process that results in atrophy. What happens if you have cystic fibrosis? Cystic fibrosis, you see that the secretions pretty much across the body are going to be, become thickened. This is why those patients may die actually as a result of, asphyxiation. And one of the ways for asphyxiation to happen is that their secretions in the bronchi in the lung is going to be so thick it's going to block actually the airways, resulting in no oxygenation, or no aeration of the lungs. Now, example of other thick secretion is going to be at the level of the pancreas, where those pancreatic secretions will become very thickened, to the point that actually they are going to result in mechanical obstruction of the emptying of the pancreatic duct into the ampulla of fatum. So much so that this duct actually will become so dilated that it will compress nearby tissue, resulting in their atrophy. Another example, if you have someone who was born with a diaphragmatic hernia that resulted in actually escaping of the abdominal organs into the chest, they will compress the lung, right? As a result of that, and if that's not corrected ASAP, what's going to happen is that the lung itself will suffer atrophy because there is no space for its expansion. Okay, so all are example of atrophy. How does it happen? Here's an example of that: adrenal atrophy, empty cell syndrome. When you say empty cell syndrome, the question is, where did the pituitary go? In this case, it could be resulting from many things. For example, pituitary infarction, a surgical intervention on the pituitary, a tumor that actually necroses the pituitary. All of them will result in simply the house of the pituitary, which is the cella torica, becomes empty. And as a result of that, you will start to see, all end organs suffering, actually, atrophy. Example of that, as a result of loss of ACTH, the adrenal becomes shrunk. Now here's a testicular atrophy in someone who is above 70 years of age as a result of the atherosclerotic plaques in the pelvic vessels. That's going to result in less blood supply going to those testicles, and you will see that compared to the normal testicle, it becomes much smaller and much denser. And then there is the normal brain versus the atrophic brain, as we have mentioned. You start to see that that there is what you call global kind of atrophy of the cerebral hemispheres. There are thickened gyri and widened sulci, right? Resulting from the fact that there is a loss of brain tissue, brain material. We finish this and then we stop. What time is it?
54.
5 minutes to go, right? All right. So now we're going to be talking about how does that happen. Now remember, in this case, remember two mechanisms. The first one is what you call the ubiquitin proteasome pathway, and the second one is going to be called, just 1 second, the autophagy lysosomal pathway. Both these pathways converge on the muscle fibers to result in atrophy. Okay. Now, what happened actually, during normal development, during the life cycle of man, you will see that there are always these two trends or these two currents. There is one that is going to result in muscular growth, and the second one that's going to result in muscular atrophy. And those currents are in check of each other, are in balance of each other. Okay? So what happened actually, as time goes by, either as time, or as a result of a pathologic condition, loss of hormonal stimulation or compression from a nearby tissue, you will start to see that the muscular or the muscle atrophy, axis, if you will, is going to dominate. Right? And that's exactly what happened between the two of them. So the first one is going to be the ubiquitin proteasome pathway. Regardless, of what started it, regardless of the inciting or the original insult, either as a nutritional deficiency, blood supply deficiency, a compression, loss of innervation. The result of that, you will start to see that a special set of enzymes known as ubiquitin ligases are going to go and label the proteins that are the cellular proteins for degradation by tagging them with a special protein known as ubiquitin that is going to set the stage for degradation. So that's what you call the ubiquitin proteasome pathway. The second one, which is autophagy, also known as self-digestion, in this case you will start, is a much easier way to actually to think about it, because in this case those cell organelles that are destined to be degraded are going to be surrounded by vacuoles, and those vacuoles are going to fuse with the lysosomes, and the lysosomes will take care of the rest. Now, what's going to oppose the ubiquitin proteasome and the autophagy lysosomal pathways are going to be a set of transcription, a set of proteins, transcribed proteins that are going to oppose actually the enzymatic effects of the two pathways. One of them is the FOXO, and another one is a nuclear factor that are going both to keep the two pathways in check. For example, one of the things you see how actually diabetics end up with muscle wasting is the fact that FOXO is actually degraded or is inhibited by the insulin AKT pathway. So when it is inhibited by the insulin, what will happen to the nucleosome, to the ubiquitin proteasome and to the autophagy lysosome pathway? It will become dominant because there is no longer inhibition to it, or there is no balance to it by the FOXO, because the FOXO was actually knocked down by the insulin axis. Do you guys see what I'm saying? Any ideas, or did I do this? I lost you somewhere a long time ago, right?
You were talking
So
about.
what happened? What happened? Wait, what happened to diabetics? What happened to the insulin level? Through the roof, right? It's especially type 2, right? That's a insulinemic condition, correct? There is insulin, but you cannot use it. So when there is insulin, I'm telling you, insulin will inhibit the FOXO, and FOXO will inhibit these two pathways, the degradative pathway of the muscle. So what happened as a result of that? So that the two pathways, the degradation pathways, will become prominent because there is no inhibitory factor to them. Does that make sense?
Yeah.
Okay? As an example, I did not put it here, but as an example. One last thing before actually we finish is that as a result of this degradation, what's left in the cell is fat. How does fat looks in tissue? Yellow, right? So that's what you call actually, if there's a lot of this, degradation that's happening, a lot of atrophy happening, the tissue itself will take, a special, color, that's a brown color, yellow color, what's known as a brown atrophy. Example of that is what you see at the level of the seminal vesicle. That's in direct continuity with the in a direct like surrounding the prostate, and this is an example of this actually atrophy. Okay, we'll stop here. We have like 4 or 5 slides. We finished, so there's no reason for an additional lecture for you. I know you don't like